Well, everyone, thank you for attending today. This is Tim Colbago. I'm going to serve as your moderator today. I'm the CEO here at ImageIQ. And today's webinar is really a very interesting webinar. You know, in the series of webinars that ImageIQ has done for folks, it's been very exciting that we get a lot of feedback from all of you, and we welcome that feedback. And one of the pieces of feedback that we've gotten is that our webinars have been very interesting, but they'd like us to, that you would all like us to go into a little more technical depth around the webinars. And so as we were coming up with our next webinar topic, we decided to do something here a little bit about image analysis in oncology clinical research, and I think you're going to be amazed at the depth of knowledge that our presenters have today. So let me give you a little bit of kind of the basics here in terms of what we're going to do and how the webinar is going to work. So we're going to probably be presenting for about 45 minutes, and we are recording the webinar for you. So if you or a colleague have to leave early, or you think there's a colleague who would enjoy this webinar, literally when the recording is done, we'll get it up on our website probably by the end of the day. So that's really, really great. Logistically, we've got a really nice turnout today in terms of the number of folks here. So obviously, we can't open up the line for audio conference part of the webinar. So what we can do, though, is in your GoToMeeting, you'll see a little question mark box where you can ask us a question, and that question will come to me privately, so not everybody will see your question. And what I'll do is, if we have time at the end, we'll try to get through as many of those questions as we can. So you're welcome to ask a question during the flow of the webinar, as it works, as the question comes to you, and then we'll try to capture those at the end. If we can't get to your question, we are happy to reach out to you via email or something, and we can have that conversation. So as the last set of people come in, I think it's really kind of fun to start these kind of webinars with a story that kind of put things in context, and we've started with a few stories. So many of you may know that I play golf, and I'm sure a number of people on the webinar play golf. And this is kind of an interesting story that I think really kind of sets the tone for today's webinar. Earlier this year, I made, you know, your success at golf has really nothing to do with your athletic ability. It has everything to do with the equipment you have, right? And any good golfer probably, you know, knows that you got to do that. Well, you know, back in the old days, kind of this picture up here we have on the left is, you know, the old feather-filled ball and a wood. I mean, when's the last time we've seen a wood? And you grabbed your stick and you grabbed your ball and you went out to the golf course and you played pretty well. But technology advances and technology changes, and your ability to have your equipment match your swing and what you're able to do also changes. These are actual screenshots of a fitting process that I went through to get a new set of golf clubs. It's amazing. You get in this thing, they put this harness on you. I mean, it's a Velcro belt that you wear like over your belt so it can measure your hip turn, and then you wear this thing like a backpack, and it measures your shoulder turn and all this other stuff. And then there's this, you know, stereo vision system that measures every time you hit a ball, and it feeds us into this system, and then this expert system comes out and says, based on all the data I've acquired from your swing, I recommend this set of clubs for you. It's spectacular, and I think that really sets the tone for the kind of things we're going to talk about today in our webinar, because really, you know, we have ways of doing things today in oncology clinical research, but there are maybe some better ways coming down the pike. Now, when we did our rehearsal, by the way, it was important for me to mention this, that having gotten the new golf clubs, strangely enough, the new equipment didn't really help my game. So there's probably something else involved. But I know. Could you believe that? It's like, seriously. But it was fun to go through the process. So look, today what we're going to do is we're going to talk about a few things. And as Andrew mentioned, and we'll introduce our presenters here in just a second, we're going to talk about the RECIST criteria, how it's viewed by the FDA, what its limitations are, what the community is talking about relative to this standard for assessing tumor response. We're going to talk a little bit about human image scoring and how does that work and what are the challenges there. And Andrew's got a really great slide to describe how this works and where some of the errors might come in. And then we're going to talk about an alternative where we're actually seeing a movement in the industry, and obviously this is ImageIQ's part of the story as a group that does imaging software, where quantitative software analysis is starting to be looked at as a way to assess tumor response in these images. And what are the advantages? Like anything, it has limitations. And really, what is the industry saying? We're going to talk a little bit about something called KIBA, which is really good and an important word to know if you play Scrabble. because you don't need a U with that Q apparently. And then we'll talk a little bit about what do you need to do to prepare yourself to use software and what's going to happen. So that's really what we're going to cover today. It's super exciting. So let me start by really introducing to you the people who you're going to hear from most. Starting on the top with our Chief Technology Officer here at ImageIQ is Dr. Amit Vasanji. Amit's got well over 10 years of experience in basic and clinical research focused around imaging, image acquisition, image processing, analysis, visualization, all with software. He was the founder of Cleveland Clinic's Biomedical Imaging and Analysis Center and actually served as its executive director since 2005. And during that time, he's authored over 30 publications in journals and grants and all over the place at the federal level, the corporate level, and the state level for grants. And he's actually won numerous awards for innovation. So Amit, thanks for being here today. In addition to that, we've got a wonderful friend of ImageIQ's and someone who's really well known in the industry relative to his research and his work as a MD and PhD. So we're happy to welcome Dr. Andrew Smith to our webinar today. Andrew, thanks so much for being here. This is wonderful to have your expertise and your insight. Andrew's an assistant professor and director of research at the University of Mississippi Medical Center. Amit and I sit in Cleveland, so Andrew's somewhere a little bit warmer, although it's raining. He's the president and founder of a company called Radiostics, which is actually an imaging lab that focuses on oncology trials for the pharmaceutical industry, but it also provides core lab services for like a broad array of other areas of research. They're a great group of folks over there in his core lab. And he's got a lot of areas of expertise, not the least of which are clinical trial design and grant writing with specialties in CT, MR, and PET-CT, as well as ultrasound and 3D imaging. And, you know, very honestly, we could go on and on and on. But from the ImageIQ perspective, Andrew's truly a visionary who brings a real fresh perspective to how imaging can impact the results of the work that you all do to improve patients' lives. So, Andrew, thank you so much for your time in the rehearsals we've done and putting this webinar together and for being here today. I really, really appreciate that. With that, I'm going to turn it over to Andrew to get us up to date on the state of the art for clinical trials, and I'm going to stop talking and let you all hear what our experts have to say today.
Well, thanks, Tim. As you recall, for payment for this webinar, you agreed to do that for me all next week over the hospital speakerphone when I come into work. So I can't wait to hear what my colleagues say after that.
Not a problem. Not a problem.
So many of the people on this webinar are probably familiar with RECIST, but if you're not, we do want to review it for you here. So originally, RECIST 1.0 was established in 2000, and then an updated version, RECIST 1.1, as we say, it came out in 2009. And so a number of clinical trials that are ongoing, some of them still use RECIST 1.0, but we're going to focus today on RECIST 1.1. As you probably know, it's the most widely accepted means for longitudinal assessment of tumor response to therapy in oncology clinical trials. And it has well-defined metrics for choice of target lesions and for categorization of disease response. And so we're going to talk about that and then also some of the pitfalls related to it. So just to kind of understand how do you do RECIST 1.1, typically you're going to obtain an MRI or CT. It does also potentially include PET-CT, but the main focus is usually CT, ideally with 5 mm thick slice thickness or less is typically what we would recommend. You're going to identify up to 5 target lesions. That's per RECIST 1.1. You may know that RECIST 1.0 had 10 lesions, but 1.1 has 5, and up to 2 target lesions per organ. And you're going to perform some length measurements. Things have changed a little bit for RECIST 1.1. You're going to stick to the longest dimension for most lesions that are over 1 centimeter, but for lymph nodes, we kind of redefine that, and you're going to choose a lymph node that has at least a 1.5 centimeter in short axis length, and you're going to stick to the short axis length for lymph nodes as you follow that. You're basically going to calculate a sum of these target lesion lengths, and then you have to, as you're performing RECIST, you also have to account for other non-target lesions. Those are the lesions that, if there's more than 2 in an organ, they still could be big. It's also the ones that are smaller. It's the harder to find things or define, like pleural effusions, ascites, and so forth. And then as you go throughout the process of RECIST, you're going to evaluate for new metastases and then categorize disease. So here's how you would categorize disease. Most of you are familiar. There's 4 different categories: complete response, typically is disappearance of all lesions. Technically, you could have some measurable lesions that are lymph nodes less than 1 centimeter. Once they get less than 1, we consider them no longer pathologic. So you could have a measurement of a lymph node and still have complete response. Partial response would be a greater than or equal to 30% reduction in the tumor burden. And then stable disease is basically not progressive disease, either a less than 30% size, I think I might have this written in here, size, less than 20% size increase or less than 30% size decrease, and no new metastases. Progressive disease is a greater than 20% increase in growth, where you have to have at least a minimum of a 5 millimeter absolute value rule. So if you went from 5 millimeters to 7 millimeters, that may be more than 20%, but it doesn't meet the 5 millimeter rule. So you have to have at least a 5 millimeter increase. Presence of new mets that are confirmed as new mets is definitely progressive disease. And you can also define progressive disease as unequivocal progression of non-target lesions. That's pretty uncommon to call that, but it does occasionally happen in clinical trials. Here's kind of an example, just walking you through kind of a basic RECIST. Here would be a patient that had 5 target lesions, maybe 4 of them are mets in different organs. So perhaps 2 are in the lung, 1 in the adrenal, and 1 in the liver. And we would measure the longest dimension of those mets. But for the lymph node that's shown here, you'd measure the short axis. And you essentially take a sum of that. So this is their baseline exam, and they have a 10 centimeter total tumor burden. After starting therapy, let's say this is 3 months later, depending on what therapy you're doing, that could be several cycles. You know, we have a tumor shrinkage here. It got to 8 centimeter. And so what percent is that? We'll show you here. That's a 20% decrease. Well, that's not enough to meet partial response, so we would still say that they have stable disease at this point. And we go forward in time. Let's say this is 6 months. Now it's decreased even more, and now it's 6 centimeters in size. Well, you actually compare to the original baseline exam here, and so we have a total decrease of 40%, and now they met partial response. It's certainly not complete response. They still have disease here, but they're at partial response, which is good for them. Let's kind of move forward in time here. Maybe this is, I use this as 9 months here. This could be much further down the line, potentially. They've started to increase in size at this point, and that's not necessarily a good thing, of course. But let's look at their percent. How much did they increase in size here? About a 17%. So your new baseline then becomes where their lowest measurement was. So you're now comparing to the 6 centimeter and saying that's going to 7 is a 17% increase. There's still stable disease at this point, but let's move forward in time and take another look. Now they've increased again up to 8 centimeters, and if we compare that to the 6 centimeters, that's a 33% increase. And so at this point, they do meet progressive disease. You'll notice they never got back to 10 centimeter, their baseline measurement, but you can still have progressive disease and never hit your baseline measurement. And that's what happened in this particular patient. This is kind of the overall review, and a couple of terms in there. There's their best overall response was partial response, and their duration of overall response is from the time they met their best response to the end of therapy. And so we have that shown as well on the top. That's kind of the general overview of it. There are some limitations to RECIST. We don't really use it in mammograms because, of course, you're compressing breast tissue in the mass. We don't typically use it in ultrasound. It's not necessarily reliable in that the axis you choose could vary with ultrasound. It's not particularly appropriate for brain tumors. You literally could use it there, but we don't typically do that. We don't use it in cystic neoplasms or cysts because cysts have a lot of fluid component, and that would account for a lot of their size. So it's sort of, you don't really want to be measuring the fluid. You want to measure the solid component of the tumor. It does not account for paradoxical increases in size of lesions that have internal hemorrhage. And that's kind of what I've shown you here below, is that we have an example where there's both CT and PET CT. And you can see that after therapy that, there's definitely something that's happened there. What's happened is this tumor's hemorrhaged, could have cystic degeneration. There's a variety of terms that you could use for this. The overall amount of solid tumor is about the same. However, if you measured the longest dimension, you would get an increase, and you would call this progressive disease. Probably not actually what's going on or reflective of how the patient is responding in this particular case. Okay, so some other limitations of RECIST. It does not account for cavitation and lung target lesions. So in the baseline here on the far left, we have like sort of a bilobe, large mass in the right lung. And then after therapy, what a tremendous response. But you wouldn't pick that up by RECIST. If you measured the longest dimension here, you'd say, well, it didn't really change very much, But But if you look at how much of the tissue is gone, it's necrotic, it's air-filled at this point. What a tremendous response they had. So RECIST doesn't really pick that out. This is well known, and there's a lot of new therapies that do this kind of stuff where they cause necrosis, and RECIST sort of underestimates their response. And you'll notice eventually as it comes back in at cycle 9, starts to fill in with tumor. The longest dimension isn't increasing much, but what a massive change in the amount of tumor burden compared to like cycles 2 and 4 by the time they get to 9. So RECIST is designed for classic cytotoxic drugs that shrink tumors, but that's not as useful as targeted agents, which we consider more cytostatic at times. They usually have both components, cytotoxic and cytostatic. And size changes are less common or less dramatic when you use these agents, despite increases in overall survival. So that's a limitation. And so a particular case where that might occur is if you're using an anti-angiogenic targeted therapy. RECIST is not ideal for localized disease or assessment of the primary tumor. I mean, you can use it, and it is used, but for rectal tumors, cervical tumors, endometrial, and the other ones listed here, sometimes those are better measured in other axes. I mean, typically you're using the axial dimension when you're doing RECIST. You don't have to. You can plan ahead if you use an appropriate protocol, the right type of pixel size and slice thickness. You can generate coronal and sagittals and measure off of that, but you really need to define that up front. And so sometimes these tumors tend to grow more in the craniocaudal dimension or more in a volumetric process that may better capture it. So here's an example down below on the 4 panels on the left. That's pre-therapy. It's a renal metastasis to the retroperitoneum. It has enhancing components. You can kind of see centrally where it's not enhancing. And they went on anti-angiogenic therapy in the 4 panel on the right. And the tumor did shrink. If you look at the long axis, it didn't quite meet RECIST guidelines of 30% for partial response, but it's an over 50% decrease in volume. And boy, look at this thing. It's not enhancing at all. You'd almost wonder if it was dead. And since this was a solitary metastasis, they actually took it out, and it was, in fact, necrotic and a dead metastasis. So sometimes there's other components besides just longest dimension that we might want to consider depending on what tumor and therapy we're looking at for a clinical trial. Okay, so just in general, how do we use this in clinical practice? It was interesting. I was just at a national meeting, and a few people were saying, we use RECIST every day as radiologists. And I sort of argued that, well, we try to, but I don't know that we really do. And I'll sort of explain that here. And this is why you might want to consider a core lab and software and so forth, because your radiologists may not be using RECIST exactly as you think they are. So first of all, when in clinical practice, I really wish that we would have all the clinical information when a case comes through and I need to read it out. But oftentimes that's not the case. The patient comes in, they get their CT scan, then they go to the oncologist. So when I'm reading that study, I don't even know, are they still on therapy? Have they switched therapy? What is going on? And so I'm often reading blinded. From a clinical perspective, that's not necessarily the best thing. You may say, well, that's okay for me in my clinical trial. But it does get kind of confusing. The radiologist, even in a clinical trial, needs to know, did you just start therapy? Is this the baseline? Should I pick some new target lesions, stick with the old ones? You know, it does get a little bit confusing, and communication can break down. You may get a different radiologist at each time point. That causes some variability. Sometimes the radiologist starts picking a new target lesion. Ideally, they'll pick the same one. We tend to do that. But they may decide to measure it a little bit differently. So long as they're measuring the longest dimension, that's fine. It doesn't have to be in the upper left to lower right sort of concept. They just have to pick the longest dimension. But sometimes you get a lot of variability in how someone would define the longest dimension. Imagine a spiculated nodule or something like that in the lung. Very difficult to reproducibly do that, especially if you switch who's making the measurement. So RECIST.
Hey, Andrew, real quick question for you. Yeah, just real quick. So you mentioned RECIST 1.0 had a 5 nodule.
1.0 has 10 lesions, and 1.1 has 5 lesions.
So it's reduced in 1.1. How do you guys? How does the radiology community pick those lesions? Is it like the biggest ones, or is there a standard for that as part of this, or is it?
It's defined in a number of different publications. You do tend to want to stick to the biggest, but reproducible tends to trump biggest. So typically you're going to use the biggest, but occasionally that, for some reason, just the way it is, the shape it is, location, borders are regular, that sort of thing. Sometimes you'll skip the biggest and go to one that's a little bit smaller that's more reproducible. And that's another source of variability, is I may say, oh, this one's more reproducible, and someone else may say something different. If you're using a large pool of radiologists, you can get a lot of variability in that, which is we'll come to. One of the advantages of a core lab is that you have less radiologists, maybe a single radiologist who's focusing on that.
So could you argue that, sorry, Andrew, could you argue that you may get radiologists that would pick the easier ones to sort of measure because, you know, you can reproduce them, but in fact, those are probably the ones that you don't want to look at. You want to look at the ones that are irregular shaped that could be metastatic?
Absolutely. I mean, it depends how you define you want to look at those. You want to look at the one that's most reproducible because humans do better with that, but that's where like your software stuff comes in, where it may be the software does a much better job of being more reproducible and could handle that irregular margin lesion or something, especially if you're doing volumetric. You know, I mean, how far out do you go in the speculation? You know, when you're doing it manually, it can be very tough to decide that.
Right.
So those are good questions. Okay, so yeah, in my experience, it's difficult. Some radiologists don't quite fully understand RECIST. I mean, we think we do because it's based on longest dimensions, but the categorization of disease part is difficult for them. And so here are some things to watch out for. A new MET may not be new. I mean, if the radiologist does or doesn't know if they just started a new therapy, how do we know if this is a new MET on the old therapy or new MET on the new therapy? And sometimes another thing that happens is a lesion can disappear and then sort of reappear. And that can happen. It can disappear like a year ago and reappear later. It's not really a new MET in that sense, especially if it was previously a target lesion and no longer has been followed. So it can get confusing over time for the radiologist, a little bit different than a core lab where you can potentially go back in time and find that target lesion because you have the appropriate documentation to find it. As we said, different radiologists measure things differently, so size changes may just be due to differences in technique. Oftentimes in real life, we don't really do the same sort of description of non-target lesions. I mean, we do tend to give some description of those, but not the same way strictly per RECIST. So what I'm trying to convey is there's a little bit different between clinical practice and clinical trials and how you handle tumor measurements and stuff. And another example is here. RECIST progressive disease has very strict definitions, but the radiologist may not know that, or maybe locally they're used to just saying, hey, it increased a little bit in size, progressive disease. Well, obviously, we have strict definitions for that with RECIST, and so some radiologists aren't necessarily familiar with that. So I'm personally very cautious. If I don't see a massive increase in size or new METs, I don't bust out the term RECIST progressive disease. I'll just say it's increased a little bit in size, and I'm not really sure where they are in the therapy. Is this a new scan, new treatment, or whatever? So I'm a little more cautious about handling those lesions. So these are just kind of ways, recommendations about planning ahead. If you're on the phone and you're saying, you know, if I ask you, are you certain you know how to set up an imaging protocol? Meaning, do you need thin slices? How do you translate this across multiple different scanners, vendors, and sites? If you're not really familiar with that, that's a good chance for you to say, geez, maybe I should get some help. Especially, what if this happens to you and you don't get the results that you were anticipating, and you're borderline, or you have a new drug and the FDA wants some additional data? Having the right protocol, deciding up front, do you need to capture the images or not, is a critical question. So get a consult on that. Ask the experts. Are you certain you don't need centralized image archiving and review? You know, sometimes the FDA wants that. Hopefully, if you're working on a new drug, they're going to tell you if you need that. But really consider it. I mean, even if they're not telling you, you know, you're going to get standardized interpretation, data tracking, a lot of other advantages with the centralized core lab that we'll talk about in a minute. We'll get to here shortly. So just be sure to plan ahead. Talk to the experts as you plan in your trial.
Thanks, Andrew. I thought it might be interesting to actually give you some sort of output on what kind of variability you might get with an observer-based sort of assessment. So Andrew talked about how there are deficiencies in RECIST in terms of how well are you defining response. And so the volumetric analysis has been shown to actually be an improved option in actually defining response. And there's a lot of papers that actually go through that. I thought this was actually kind of interesting, this sort of study that was showing you, even if you are making a RECIST-based measurement, there's variability even in that sort of measurement. We sort of touched on that a little. earlier. So this study was conducted in 2003, and there were 5 radiologists with 4 years of experience, all in and had a thoracic fellowship. They made unidimensional longest axis measurements, and so the longest dimension, and so I think they also did bidimensional, but I'm only going to describe the longest dimension. And they had 40 tumors, and there were all different types of tumors. There were some that were more spherical and lobular, and there were ones that were very sort of undefined margins, very irregular, and they were across about 33 patients. So for the 2 images that are shown here, the one on the left is a lobular tumor that has really clean boundaries, and the percent variability for the longest dimension measurement was about 7%. And then within an observer, it was around about half that, or about 4.8%. If you look at the one on the right, which is more of an irregular shaped lesion, it's around 140% in terms of the longest measurement. And you could sort of understand that if you were trying to make a longest diameter measurement on that lesion, it'd be really hard to do. It's kind of hard to determine which is the axis that I should, or which is the line I should draw. What was neat about this particular study is that they sort of went old school. Instead of letting the radiologist open these images on their PACS viewer and adjust window and level, they actually printed these out. And so that was fixed, and so they didn't have the opportunity to do that, which would cause some variability in how you window and level. They actually had these printed and let them use a ruler. And they even showed the radiologist which slice to make the measurement on. So that took a lot of the variability out of this. And so this is really just how variable somebody in making a line measurement would be off with respect to other observers, right? And so the table on the bottom, based on RECIST for progressive disease, the criteria, how many misclassifications they had for a tumor, and these are like comparing observers one to the others respectively. And there was about an average of 10 misclassifications of a specific tumor based on the criteria, and they did it for response too, and it's about the same. So this is so variable, even if you're just going to use RECIST, right? You're just having people draw, or observers draw, like lines on an image, and that causes a massive amount of variability. So, what are your options? Well, instead of using RECIST or even the manual volumetric, is there another way that you could do this that would be more sort of reproducible? So there are a number of software vendors, including ImageIQ, that actually have software that does an automated measurement of lesions and nodules within lungs or other organs as well. And so I thought, just to give you an example, this is a specific patient case study that we applied our software to. This was a CT scan of a patient that on a 128 slice scanner with thin slice sections, so 0.6 millimeter sections. They were reformatted for 3 millimeter increments. And they had, contrast injected, as most studies do. And then there were, in this case, 2 specific time points. And I chose these because they were further enough apart to see the differences. But obviously, for a trial, you may actually have more time points between those. But these are 17 months apart. And so this is just an image of, or a slice pan through of, actually through a patient that had these nodules. And you'll see them. And I apologize, I should have window and leveled this a little better, but you can see some of the nodules appear and disappear as you go through the lungs here. And you can see how challenging it is even for a radiologist to make these measurements. And there's so many in this particular patient that it's, trying to track all of them would be, sort of a daunting process, especially if you're going to do this over multiple time points, right? I thought this was kind of a neat sort of an example of what in clinical practice you would get in terms of a report, right? And so this is very unstructured. I don't expect you to read all of this. I apologize for all the words. It's just showing you what the actual measurements are. I highlighted areas where they're actually comparing, the radiologist compared this particular scan to the previous scan and making measurements, but very unstructured. You wouldn't necessarily get this for a clinical trial. You will actually have a CRF that has specific measurements of specific target lesions that you're looking at. Very, very structured, right? But this is just the sort of the general way that you're presenting this in a clinical practice. I don't know if Andrew, if you agree, this is sort of what you would generally do.
This is like, a pretty typical PROS type report. Some of us are trying to move more towards a standardized and make it easier on the eyes, where target lesion measures this, previously that. But most reports look like this, and a lot of study coordinators are going through our reports and pulling out the dimensions, and things get lost. I mean, in terms of, am I looking at the right lesion if they didn't give a table position or a slice number? And then other things that happen are, I've seen that study coordinators get confused on craniocaudal dimension. They'll list that one because that's the longest in some tumors, but for that particular trial, maybe they didn't want craniocaudal. So things can happen with these prose dictations and clinical trials that you don't necessarily want.
Right, and it's an argument for using a centralized reading center to do these, because if you're using the site radiologist to actually make these measurements, you're going to get this report, and a study coordinator is going to have to translate it in some way, and then it has to get put into some sort of EDC or a report back to the sponsor. So having a centralized reader, you could give them a structured CRF to actually make the measurements. So, applying our software to this analysis, and again, there are other vendors that actually create software. This isn't a pitch for ImageIQ, but this just is an example for this particular patient. What you'll see is as I pan through the same tumors or nodules that are in the lung, the red that you'll see in a minute is the segmentation of the second time point of all of the automated segmented lesions, and then in green is the first time point. So it's overlaid, and what we required for this sort of analysis is that the two scans from the two different time points were co-registered so that they're in the same coordinate system, and then you can track each of the lesions with respect to one another over the time points.
I'm all about color, Amit. I like the color there. Two different time points displayed in two different colors on a single image is pretty helpful.
Right.
It really paints the picture nicely. Yeah,
and that's a good point that you bring up. You can choose how you want to use automated software. You don't necessarily have to basically say, I'm going to put it on my PAC system and let it run over all these scans. You can have the software as a CAD, right? Your computer-assisted diagnosis, where you're having the radiologist look at the outputs of the image and make their own assessments and say, yeah, I agree or I disagree, and have a sort of an input, right? Not necessarily let it drive on its own, right? This is just another view of that same patient, but now in 3 dimensions. It gives you a better sort of view of the tumors that they're not round, they're not spherical, they have this specific morphology of volume, right? And the red, again, is the second time point, and the green is the first time point. And you can see that there is appreciable change in the size of the tumors, even the shape of the tumors over the 2 time points. What's interesting that you can sort of pick up here is that there's a shift in these tumors, and it's not because the tumor was moving, it's because the patient in this particular study or case study didn't keep the same breath hold between the 2 time points. And that, makes sense in a clinical practice. You're not asking them to do that. In a clinical trial, you're probably going to say, keep this breath hold sort of consistent. But, as you get closer to the diaphragm for this particular nodule at the bottom here, it gets shifted quite a bit. And this is where you could have software say, you know what, it's within a specific, centroids are shifted by a specific amount. It's probably the same nodule. Whereas if you had a radiologist try to put these side by side and they're not registered, it would be a hard time having to define which nodule belongs to which, where it sits in the next time point, right? This is just an example of some of the outputs, and there's actually some columns here that are not on this sheet that are missing. So some of them, the volume of the tumors, obviously, or the lesion is obviously important. The mean diameter, the longest diameter, which is again, a throwback to the RECIST criteria here. I thought it would be interesting to actually include what the estimated volume would be based on the longest diameter measurement. So assuming that the lesion or the nodule was actually a sphere, what would the actual volume be and the percent change associated? Mean density is important as well. Centroids here are basically to track the nodules and find out where they are located from one time point to the next. What's missing is, morphology, like how spiculated the tumor is, how rough the tumor is, or the nodule is. And those are things that we can output using software, right? It's harder to do for somebody a manual observer that's actually drawing around the nodule. You can look for cavitations.
The data is very structured and comes out for them. I know you're going to talk about the volume here, but I also see attenuation or density on there as well.
Right.
For some of the people on the phone, they may be studying certain types of tumors where they're going to use a criteria that incorporates density measurement, whether that's liver tumors or GIST tumors or other it also depends on the therapy too, not just the type of tumor. So these organized outputs are very helpful for those kind of trials.
Right, right. Yeah, that's a good point, and especially when we talked about when you mentioned earlier that some of the tumors will have cavitation, things like that aren't really taken account for in RECIST, but you could in this case change in terms of the mean density unit as well. So, and so I just want to call out specific changes in percent of specific, the specific nodules here in terms of volume versus longest diameter, right? In every case, in every single lesion here, there's a massive amount of underestimation for the change in the volume of the specific nodule if you're using longest diameter. The volume is much more rigorous in the way that it's actually making that estimate there. It's particularly for the one at the bottom here, where there's actually the longest diameter here is actually decreased and shows a small change in the size of the tumor for the better. Here, it's actually showing that there's actually 80% increase in volume. And calling out, let's say you're going to say RECIST is the all-encompassing, criteria for making measurements, and you're making the assumption here that the longest diameter is a surrogate for volume, and let's say we're going to assume that the longest diameter you can extrapolate that out to a volume based on it being a sphere, right? The change, if you do that for one of these particular tumors, is a 25 time increase, a 2,000% increase in the change of the volume of the tumor based on volume. It's actually only 4 times, right? 4.25. It's 400% increase, right? This one again, and I called this out earlier. There's actually a decrease based on the longest diameter measurement. There's actually an increase in the volume size here. And at the bottom here, I've noted. Let's say you use the criteria as Andrew sort of outlined earlier in one of the examples, where you sum all of the longest diameters. There's actually a percent growth, in some of the longest dimensions of 72%. If you use volume, it's actually 310%. So it's a massive difference in the amount of the change in these nodules.
Hey, Amit. Let me ask you a quick question then. So I'm looking at this going, man, this looks just like that spreadsheet I got from my, my golf club fitting, right? I know it sounds silly, but I mean, there's a lot of data here. I would imagine people are sitting here going, well, gee, at least the RECIST criteria, it kind of bins nicely, right? I know what to do with that, right? I know how to make a decision based on that. What happens? I mean, I guess this is both for you and for Andrew, but what happens with all this data? I mean, what do you do with it, and how do you assimilate it in some way that makes sense? Are you trying to tell a different story, the same story? Do you map this to the RECIST criteria, or does this data stand on its own? Does that make sense as a question?
Yeah. I think it's actually sort of counterintuitive to create. So the reason for things like the RECIST or scoring systems that you see out there is because it's hard to get a consensus between observers, right? So you have to give them specific criteria so that you're evening the playing field. You don't have to do that when you have numbers in a quantitative output, right? They speak for themselves. You just use the numbers the way they are. Now, how you want to use the numbers is a different story, but at least now you have the option of actually diving into the data and getting out new metrics that you may not necessarily have seen before. And you can categorize disease better than you did before, and it becomes, I understand, it becomes more of an exercise in research and development, but at least opens up new sort of ways of thinking about disease, right?
Right. You can define it up front and use the data directly in your trial, or you can say, you know what, I want that data just in case at the end we really need to do some additional research on this, and perhaps the RECIST is unimpressive to the FDA, but you say, look at this volume change. It's 50% change in volume. So it gives you opportunities that you wouldn't otherwise have.
Right, and it sort of speaks to why you would want to do this up front in a clinical trial too. Let's say you had your drug approved based on RECIST criteria, and then you were trying to sell this on your particular drug on the market, and you had some clinicians say, I wanted you to tell me how much change in the volumes you have, not necessarily just the longest diameter, because that doesn't make any sense to me. Well, now you're going to have to go back and redo all of the images that you just already did and have radiologists actually draw outlines around all of the volumes. If you had done this up front with actually automated software, you didn't have to worry about any of that stuff. So you have the data because you ran through it once, right? So you might ask, what are some of the technical requirements for doing a software-based assessment for nodule assessment, right? one of the things that I sort of alluded to this before is, try to get consistent breath hold between time points. Have a consistent image acquisition protocol, and I'll sort of cover this a little bit later on some of the key parameters that you want to sort of look for and make sure they're controlled. Have calibrated systems with, continual monitored image quality. This is important because you'll often get cases where, for a given trial, they'll put patients onto a research scanner, which is okay, but generally they don't. The research scanners aren't monitored, with phantoms and things like that on a regular basis because they're research scanners. So you want to make sure that they take their same protocols that they use for patient scanners and implement it onto the research scanner so that they do monitor, image quality. Have a controlled sort of contrast injection protocol. There are some places and sites that actually use just the standard of care, which is, injecting contrast and the amount of contrast, at any time and then pressing the button on the CT scanner. And that can lead to perfusion that's sort of, underserved. It sort of doesn't necessarily perfuse well enough through the entire the lung for you to see a good sort of scan. Try to do thin slice acquisition, so the highest resolution that you can. That obviously can be an issue if specific sites and IRBs require, low dose sort of scanning where you're scanning patients quite a few times. But wherever you can, try to do the highest resolution. Try to have consistent reconstruction protocol. So once you acquire your scan, you can actually reconstruct your data as a smooth sort of volume or a high contrast volume, and that's all going to affect how your software is going to sort of perform.
Matt, one thing on this that makes me kind of think about is big picture is that CT is really evolving and is highly, highly variable now across different centers. I mean, there's dual source, dual energy, and all these things, and you really need someone who knows what they're doing when you're planning the trial. It's not just about, making a simple size measurement anymore. You do need to factor in all these different things in the protocol. You need someone on your team that knows what they're doing with CT.
Right. That's a really good point. It's really important that when you set up these trials that you are actually putting thought towards the actual imaging portion of it too, not just recruiting patients and making sure that they're staying on their drugs and that they're coming in for their normal assessments. You want to make sure that the imaging part of it is also controlled, that you have site qualifications, that places are trained and they're performing things in a rigorous way so that you can apply things like automated software to it. So what some of the advantages and limitations of using software, and I alluded to some of these before. The advantages are that it is automated and there's less bias in terms of defining boundaries and things like that. There are some algorithms that require seeding with input from an observer, which are fine too, because in the end you're actually having the software define the boundaries. You get all of those measurements that I showed you before all in one pass. You don't have to go back and remeasure things. When you're looking specifically for RECIST, you're looking for the target lesions. If you're a radiologist, you may miss some of the non-targets or not realize a new MET is actually an old MET, things like that. So this, where you saw that whole sheet where it's tracking all of the centroids, it's going to do that every single time, and is less likely to miss some of those non-target ones. You get those, again, that big sheet with the quantitative outputs. Some of the limitations are that scanner vendor variability can change across sites and within themselves. The scanning protocols and parameters can affect image quality, so you need to control for those. One of the biggest things is population variability. So it's not hard to write software to make sure that you can segment tumors in one case. Getting it to work for all the patients that you might encounter is much harder to do. You've got so much variability within patients, and some things like that you can actually control in a clinical trial because you have specific inclusion/exclusion criteria. But for clinical practice, that's harder to do. And then anatomic, as well as even within an organ, the variability that you might get. So let's say for the lung, it's harder to see even for an observer, a tumor that's attached to the side of the lung or juxtaposed to a vessel. Those are harder to sort of quantify, and the tumor also, and the software will also have a problem. But at least the software will have rules around how it will deal with those situations. And then how the tumor presents itself in different organs. So a tumor in the liver looks different from a tumor in a lung. So those things that software would need to change for, or you would have new versions of that software to account for those. So, Andrew, what are some of the limitations that you see for, or advantages that you see for using software in, from a clinical perspective?
I think we've covered some of these, but yeah, I do see that it's certainly more automated and it's getting faster than ever. And so that was one of the reasons why we didn't measure so many lesions in the past. It just takes too long. It's why we went from RECIST 1.0 to 1.1, reducing the number of lesions. This software gets around that. I see that if you use it correctly in your clinical trial, to some degree you can bridge the gap between local reads and the benefits of a centralized read. So depending on how you use it, you may have some significant advantages in incorporating this sort of things in your trial. And it certainly overcomes, as you described in detail, some of the pitfalls of RECIST. Volume has significant advantages over just longest dimension measurements. So yeah, I think it possibly could be the tipping point for drug approval. If you're having some trouble using standard RECIST and show some impressive data with this sort of software, that really could be the tipping point for drug approval and discussions with the FDA.
Do you see any sort of barrier to adoptability in clinical practice, like for radiologists using the software who is experienced like yourself and sort of able to make measurements more accurately than maybe somebody who's a novice?
The biggest barrier is going to be just validation of the software. And I think you're going to kind of get into that with Kiba and stuff. That's really going to be critical. You got to validate the software, show that it works, and then once you can show that, then the next barrier is time. Is it gonna work right on my PACS? Do I have to go off to another workstation? If you can save time and make a whole bunch of measurements, have a nice structured report that pops out, it can be worked into the workflow. But those are some significant challenges to overcome.
Okay. So you might be sitting and thinking, well, there's no way that the FDA or that any sort of software could be used in clinical trial, let alone clinical practice, right? It's too hard of a problem to actually to solve, right? Actually, in conjunction with actually as an initiative proposed by the RSNA, but also involves the FDA, there is an initiative to actually apply software in a quantitative biomarker sense, right? So there's an initiative called the Quantitative Imaging Biomarker Alliance that started around 2007, and their task is to, as the mission statement says here, improve the value and practicality of using quantitative imaging biomarkers by reducing variability across devices, patients, and time. So, for this particular example, they've applied it for solid tumor assessment. There are a number of other profiles too. What they really want to do is create a roadmap for how you would validate software across multiple devices, across patient population variability for a specific thing, like, for example, tumor assessment, and make sure that you can apply it in a way that somebody who is putting in a submission or applying the software can say, look, I followed this roadmap. It follows the guidelines that was set by this Kiba, this profile for a Kiba, and I've checked all my boxes, and so now I can use this in my clinical trial, apply it to my patients. When the FDA sees it, they look at it and say, look, did you follow the roadmap established by Kiba? Yes, okay, I'm going to accept it, and you don't have to do any more validation than saying that you met those. And then you can audit that too. That's an important thing. You can go back and say, did you actually meet those requirements set forth by Kiba?
And
then there's
go
ahead.
That's a really good point, real quick. And just to keep an eye on the time, we've got about 10 minutes left before the top of the hour, and folks are going to want to be getting to their next meeting. But real quick, so often we all struggle with what's coming next, right? What's going to be the next breakthrough in our field of expertise? And it's kind of fun to see that the Kiba stuff is really that team of people is designed to tell you what is going to probably be next. I mean, you never know if it's going to work or not, or if they'll be able to accomplish their goal. But it is a little bit of a roadmap for how you can use imaging in your trials. So we do have a couple of questions. So if you guys want to rock through the rest of your slides, we can get to those.
Okay, I'll go through these pretty quickly. There's a wiki for Kiba, so you feel free to visit the site, and they actually have pretty good examples of how they've sort of gone through their process, right? As I mentioned before, it's comprised of researchers, the FDA, healthcare professionals, industry partners, and they have a mission statement to sort of identify those barriers and to actually applying software to and quantitative markers to clinical trials, and they want to account for that variability that you get from sites and from different sort of vendors for imaging equipment and time as well, right? Again, I mentioned there 6 different active areas of KIBA. There's chronic obstructive pulmonary disease is one of them. Lung density measurements. FDG PET is one of them, and then solid tumor assessment is one of the ones that we're most interested here. The mission statement for CT volumetry is actually here. It's to define evidence-based consensus, standards, and processes for CT imaging in the setting of lung cancer screening, and then to allow for quantification of biologically meaningful longitudinal changes. And that's something that's harder to do with RESIST in the current way it's implemented, right? And then once they account for that for across vendors, and what you see on the side here is an example of some of the phantoms that are used in their initiative. In their process and actually, going through the, creation of this roadmap is actually pretty unique. They've subdivided that bigger profile, bigger task of, defining software for software validation for CT tumor assessment into different subgroups, and they're all focused on different things and looking at changes in, phantoms across readers that are using RESIST, changing in, nodules in a clinical setting, comparing volume to longest dimension measurements. Looking at sources of variability from, engineering, so the vendors, right? How are the vendors' different acquisition protocols causing changes to a reader's assessment or software's assessment? The ones that we're most interested in here is 3A here, which is to characterize the variability due to algorithms. So they've actually had, I think, up to 12 different software developers apply their software to phantoms and to clinical data and compared the differences between them. For better or worse, they've anonymized all of those participants so that no one knows who they are except for themselves. And it's sort of a neat way to define how valid software is in defining these nodules. What are the different things that you need to do to validate, the software? And we touched on these quite a few times now, and so I'm sort of reiterating some of these. Try to use phantoms to define how well the software is performing. And you can use the phantoms with respect to, the acquisition protocols that might change, the different vendors, the software like Siemens or GE or Toshiba that's actually creating the scanned outputs, the different reconstruction permutations as well. Use ROC analysis to look for change, no change cases, and compare it to a reader. The reader is still going to be the gold standard. Having something to compare to and see if it's even improved is important too, right? This is much easier to do in a clinical trial because you have very narrowed, patient populations. You're able to define image acquisition protocols that you give to the sites. In the clinical practice, you don't have that opportunity. You're going to get pretty much anything, any type of scan that you may need to analyze, and it might get better down the road where people are using software on a more regular basis. But in the initial phases, if you're trying to apply software, it's going to be all over the place because the scans are, not controlled. So, and Andrew, you can feel free to sort of jump in whenever, when you have anything to add here. But how do you want to apply, automated software to a clinical trial? One of the things you want to do is make sure you have a standardized IP, right? If you're planning for a clinical trial, make sure that every site that you're using, they're using the same image acquisition protocol for the given scanner, and that includes, the parameters like field of view, KV, current, even dose control, right? Dose control for every vendor is slightly different, and that will affect how the image outputs are what kind of scan quality you get.
A lot of noise if that's not controlled. I mean, these things are pretty detailed. You really need someone who knows what they're doing to match these up across multiple scanners.
Right. And so, at ImageIQ, we use, a physicist to actually look at these scans to make sure that they're, within a specific signal to noise and, field of view is correct, so that when they're applying these protocols the next time, they have them in place, right? And so the next technician that sees the protocol knows exactly what to do. Also understand that, until KIBA goes through and software is a more sort of accepted way of doing the analysis, that RESIST is probably going to be the primary assessment, right? I wouldn't fall, on software as the actual way as a primary or secondary endpoint output. It's also important that you use a centralized core lab. In my opinion, I think it's easier to control for things like, making sure that the site's blinded, right? If you're doing the scanning at the site, the site may have access to patient information that could cause bias, right? And then
shown in
there's
trials over and over that really does lead to differences between
right.
those who are blinded, like essential read, and those aren't. And then, like the other advantages are listed here. You got a trained pool of people that use RECIST. You're going to have a fixed reader pool, a small number of people who are going to focus on the trial. You're going to have standardized image review and protocols. And if you need it, you can have two different people read with education between them when they disagree. And then these are ways that you can use with a centralized core. It's a lot easier to implement this automated software.
Right. I think it's also important that you understand where you want to put the automated software, right? You could use software as a way to flag any sort of discordance between readers. You could use it to actually, as the adjudication process, more advanced, you can actually replace one of the radiologists or even add it to the workflow for the radiologist so that they're using it as a CAD. But again, you would need some guidance from the FDA that, that's going to be an accepted sort of protocol for that trial. And then, I sort of mentioned this earlier, a lot of places aren't really focused on the imaging portion of this and training and qualifying the sites. Making sure that that's done is important because that's going to control how good the quality is of all of the scans and whether you can even apply software to the scans. That's sometimes a secondary sort of concern for a lot of trials because they're more interested in getting patients enrolled and making sure that they're compliant with their medication. But this is equally important if you're going to do image-based assessment. And then you also want to make sure that you're monitoring any sort of variability that you would get, and it's much easier to do that at a centralized site than actually across multiple sites that are doing their own reads. But you want to look for any sort of, you want to flag for any sort of weird deviations from reader to reader to make sure that there's no site doing it incorrectly or deviating from the protocol.
All right, guys, this is great. We are right at the top of the hour, so we've got a couple of questions. We've got time for probably a couple of questions, and I think I'm going to be able to handle a couple of them, and you guys help me out here if it makes sense. One of the questions we've got is, what kind of measurement variability do you see when people are using the RECIST? And I think, Amit, you covered that a little bit, right? So you can see some pretty strong variability there, right?
Yeah, it averages about 14 to 15%. I showed you some of the drastic cases where it's like 140%, but on average it's going to be about 15%, which is it depends on what your perspective is. But if you're the RECIST criteria says 20%, it's pretty close. I mean, you're going to create some issues there.
Yep. The last one, and then we'll wrap up for everybody here, is, is there any data we can share about the number of clinical studies that have used software like this? And I will throw the first answer out is, I don't think from where I sit or ImageIQ sits, we could tell you comprehensively. What we can tell you is that that has been done. The FDA likes that output if it's done in a controlled and scientific way, and it has generally been focused on the solid tumor work, right? So we know that this work has definitely been going on in the. I can't give you any more data than that. I don't know if you guys have anything you want to add.
I think I would just agree with what you said. I think that was a good summary.
Yeah,
right,
I mean, I would say that it's less. I would consult with the FDA. They're not going to, if you ask for guidance, they will actually give you input on that. They're not standoffish when it comes to using software.
Yeah, for sure, for sure. Well, Andrew, thank you very much for your time. Amit, thank you. I think, it's amazing to me how many people stay to the end of these webinars. It's just spectacular. And all of you who attended, I hope it was valuable for you. If you have any more questions, you can contact us, visit us at our website at ImageIQ.com, and we'd be happy to help you out with any questions you have. So thanks very much. Have a wonderful, wonderful day.